So we are going to the last session, and I would like to invite Professor Ray Kim to talk about viral hepatitis debrief.
Almost done. So I'm going to try to summarize the key abstracts that were presented at the liver meeting. Please note that I'll be followed by hepatitis delta, a summary, and then Paul Kuo will address emerging hepatitis B therapy. So I have deleted some of those slides from the debrief. And the debrief was delivered by Dr. Kushner, and I am just borrowing her slides. So a few hepatitis B abstracts. I picked this one out because it's about children that we don't talk too much about. And this is a large-scale, multi-center prospective study called Sprout Project. It's an interim analysis at this point. There's a large number of hepatitis B infected children in China, and it is unclear how best to treat them. So the project is a prospective, multi-center, real-world study, children aged 3 to 18. They received either monotherapy or oral monotherapy or combination with PEG interferon 2B for 96 weeks. And this data was presented at 48 weeks of treatment. 297 children were included. But majority of them had combination therapy with interferon, only 6 with oral monotherapy. And here, if you see the graph here, if you look at the total column first, surface antigen loss and E loss was much more common in combination therapy, where none of that occurred in oral therapy. Treatment naive, same thing. So this is pretty impressive number, 27% of children treated with combination interferon and oral agents had surface antigen loss. And there's there's age difference. The younger the patient, the better the outcome. So I don't know how many pediatricians are here. I don't treat kids, but interferon remains an important tool for hepatitis B infection. This is a little bit complex study. This is also a Chinese study, again using PEG-inhibitor interferon combined with TDF and making a point of surface antigen loss. This is in adults. The baseline population are people who have been on analog oral treatment, and their surface antigen titer was less than 1,500. So it's a selected group, not everybody. DNA was suppressed, E antigen negative. They were divided, randomized to TDF alone, initially, at least. And then the second group is full dose, 180 micrograms. And then the third group is half dose, 90 micrograms. So what happened here, as expected, people who continued on TDF, there was no seroconversion or surface antigen loss. End of treatment, end of follow-up, pretty good percentage of individuals lost surface antigen. And half dose did less than that, but still pretty impressive. 25% of those individuals lost surface antigen. For per protocol analysis, the percentage is higher, 41% at end of treatment and 37% at end of follow-up. So again, we don't think of interferon as a useful tool for hepatitis B patients, but E negative, relatively low surface antigen patients, if you add interferon to existing nucleotide analog, patients have a better outcome. So think about that. I don't know how popular interferon is, but that is something that we can think about. I've been telling my patients now close to 10 years that we have a new trial going on, and in maybe 5 years we will be able to cure you, but it's been 10 years saying it will 5 years they will cure you. So it is coming, as Dr. Kuo will talk about, but for appropriate patients, adding interferon may be a good idea. Okay, the third abstract is, I'm going to borrow the original slides from the presenter, and this is for pregnancy. Comparing 8 weeks versus 12 weeks, what is the best way to treat pregnant ladies with hepatitis B? And this background slides, the table explains how the guidelines differ. There's no uniformity as to when you start prophylactic therapy and for how long. Do you stop at delivery, or do you go on for a few more months before you stop? So we don't know, so far the data aren't clear what to do. So what they did was to take pregnant women aged between 20 and 40, and ALT was normal, and DNA, you want high DNA levels for prophylaxis. So usual 10 to the 5th and to 10 to the 9th. So the trial design was group 1 was 8 weeks, group 2 was 12 weeks, meaning going 4 weeks postpartum. So group A, you stop at delivery. Group B, second group, you go on for 1 more month after delivery. And they started the prophylaxis at 33 weeks of gestation. About 120 patients in each group. So decent number. And importantly, all infants received the standard active and passive immunization at the time of birth. And this is the data. So if you do per protocol analysis, individuals who completed the data, none of the baby had a breakthrough, 7% for intent to treat analysis. But this is the main result, group 1 versus group 2. Basically, if you had good application of the protocol, no babies had maternal transmission, whereas intent to treat, there was some percentage, but there was no difference. So their conclusion was that 8 weeks is enough. You start tenofovir in this case at 33 weeks, go on until delivery, you stop. And that the result is the same as going on for 4 more weeks. No baby has breakthrough transmission if you could deliver the tenofovir therapy throughout the period. So that is, I thought, helpful. Hep C. I suspect that this is not available. Is it available? Point of care hepatitis C RNA test. So this is a newly approved thing in the US last year. So you take a finger stick and you put it into a PCR machine. This is right at the point of care, and you get the result within an hour. So while the patient is in the clinic, you can diagnose active hepatitis C.
In Ankara, we do not, I mean, this machine is not available. I don't know in Istanbul. No? No.
So hopefully the data that I'm showing you here will convince public health officials that maybe this machine needs to be available in Turkey. So this was a multi-center, open-label, randomized study at 5 opioid treatment programs, people who come to be treated for opioid addiction problem. And the primary outcome was whether the hepatitis C treatment was initiated within 12 weeks. So patients come in for the program, and the first arm is applying the rapid hepatitis C treatment. And then in that arm, the patient waited for an hour. If they were positive, they were started on treatment right away. Whereas the second arm is standard of care, SOC standard of care, and they got their blood drawn. The blood was sent to the lab, and if they were positive, they were referred to hepatitis C treatment. So that's the standard way of doing things. So how much difference does it make if you can get the HCV RNA data right away, ready to start treatment? So that is the result. In the rapid HCV arm, point of care arm, 89% of the individuals started hepatitis C treatment, whereas if you do the regular blood test and send to a specialist for hepatitis, send to us for treatment, it was only 21%. So obviously different. The bottom line, what happened with SVR, of those individuals who are randomized, 61% had SVR on the point of care arm, only 13% in the standard of care arm. So this is obviously driven by how many patients start treatment. You can notice that there is some drop, and 89% was started, only 61% cured. So this is not, easy treatment group to treat. These are people who are actively using opioid treatment. So there is treatment challenges, but 61% is a significant frequency by which we can cure hepatitis C. This is, again, an abstract that I'm borrowing their original slides, and this is for genotype 3B patients, soft val plus ribavirin versus the triple combination sulf-val-vox in those individuals with cirrhosis. So as a background, for genotype 3 patients, these are AASLD and AASL guideline options. You can use sofosbuvir and velpatasvir, is this typo, with or without ribavirin, depending on baseline RAS, or you can use a triple combination, or you can use glipip. There's a bunch of, it's not my type, I should have picked up the typos, now I'm noticing them. They had a typo in their slides, so obviously that's the third option. What I did know is that there's a difference between genotype 3A and genotype 3B. Our lab doesn't usually report that out, but I don't know if that's something that you think about. I picked this abstract to tell you that there is a difference. So if you see genotype 3 cirrhotic patients, they are the hardest group of patients to treat, right? But there is a difference between 3A versus 3B here. The number's pretty small, but genotype 3B, which is common in active drug users, is hardest group to treat. So that's what the trial is about. Randomization between double plus ribavirin versus triple treatment right away for 12 weeks, and what happens. Again, these were patients with cirrhosis, DAA treatment naive, and patient had compensated liver disease. So here, this is intent to treat analysis. This is per protocol. If you start from here, triple therapy, 100% response rate, whereas ribavirin arm, the response was 81%. 90% here, 70% by intent to treat. So in this particular group of patients, genotype 3B, I don't know if the lab here reports 3A versus 3B, but at least we need to be aware that there may be a subgroup of genotype 3 patients where triple combination upfront may be more advantageous than sulfonyl plus ribavirin. Okay, so hepatitis D is going to be next, but I wanted to give you one snippet of data, which I thought was interesting. This was a hepatitis delta trial where they used anti-HBs and antigen monoclonal antibody. And this is a product, or this is a compound, basically a surface antibody that is given to patients. And 3 arms, small number of patients, phase 2. The first is smaller dose, 300 milligrams weekly for 48 weeks. The second is 600 milligrams, double the dose, weekly for 12 weeks, then every other week for the rest of the time. And the highest dose, once every 4 weeks for 48 weeks. The entry criteria you can see here: adult patients, chronic hepatitis delta, RNA positive, hepatitis B DNA need to be suppressed, compensated liver disease, and so forth. So here are the results here. Combined virologic, let me go back to show you. Their virologic response is greater than 2 log drop in the delta RNA and ALT normalization. So of all the 3 arms, there is progressive increase in the responder group. So note that the third group got started late. So this is not a non-response. People didn't reach this level. But if you look at week 24, week 36, 67 to 75% of patients who received this regimen had virologic response and ALT normalization. So I think of surface antibody, using surface antibody is somewhat of a long shot, but apparently with this surface antibody, monoclonal antibody, it seems to be enough to soak up delta viruses from the blood and be able to deal with the infection. So to summarize, hepatitis B, for prevention of maternal child transmission, 8 weeks of TAF may be sufficient, starting at 33 weeks of gestation. We emphasize the role of PEG interferon in children and adults in terms of producing favorable surface antigen outcomes. Novel therapy will be addressed by Dr. Kuo. Hepatitis C, we need to think about proactive intervention in people who use drugs for hepatitis C elimination. And in that context, point-of-care HCV RNA testing is a useful tool according to the randomized trial. I just wanted to educate myself that there are at least two different types of genotype 3, and they are difficult to treat, especially with cirrhosis. In that case, there may be a potential benefit of using a triple combination up front. Hepatitis delta, evolving new therapy, and I just congratulate you and continue to encourage you to take for your leadership in hepatitis delta studies in Turkey. Thank you.
Thank you very much. And we are going to next speaker. I would like to invite Professor Bülent Tekin about the topic is delta hepatitis. And also it's honor to see Professor Yurdaydın in Turkey. He's well known about delta hepatitis. So microphone is yours, Bülent.
Okay, thank you. First of all, I'd like to welcome everybody over here at this last session. I put a heart over here because it was Valentine's Day yesterday. So AASLD and TASL, I mean, they love each other for the good of livers. So that's why I wanted to add that heart over there. So that's me. I don't have any financial disclosures to report. And here's the topic. I mean, I'm going to talk about update on Delta hepatitis today. So here's the main topic of my talk. I'll talk about current strategies we have on Delta and talk a little bit about the updates we had last year. I'll give data on prevalence studies, screening strategies, non-invasive testing and markers specific for Delta, treatment options we have these days, and the correct way to treat a chronic Delta case. So let's start with prevalence data. I mean, in the past couple of years, we have large meta-analysis in the literature on Delta prevalence. This is worldwide studies, and as you can see over here, in the general population, it's up to almost 1% of the general population as Delta. When you look at the surface antigen ones, it goes up to 13, hepatology clinics up to 18%, and cirrhotics and HCC Delta cases make about 18 to 20% of those cases. And when you add up all these numbers, it makes about 72 million Delta cases worldwide. And when you look at the distribution of it, China is leading over here. They have about 10 million Delta cases. US is about 130,000. Europe is around between 40, 30, 50, and 70,000 cases. So it's all around. When we look at, and how about the change in the prevalence of Delta? Well, I can clearly say that it's not decreasing and it's not increasing. The answer is yes and no, because the prevalence of Delta is decreasing due to universal vaccination of hepatitis B, but it's also in a rise in countries where there is uncontrolled immigration, so that's a big issue. When we look at some numbers from, let's say, from Italy, I mean, the seroprevalence rate decreased from 25% to 8% between 1983 and 97, but it's currently 10, so it's not going down. And when you look at the Greece study, the Greek people has 2.8%, but the immigrant population has 7.5% Delta seropositivity rate. So it is a big issue when you have uncontrolled immigration. How about Turkey? I mean, we have data from 1999. It's the time where we started universal vaccination. It was about 8.3%. The study is between 2000 and 2006. It's 2.8, but there's a nice meta-analysis published from Cihan Yuraydın's group, and they reported in that meta-analysis that it was around 5% these days. So it's that study. It included 41 studies between 2006 and 2022. S antigen positive outpatient, it was 5%. When we look at the cirrhotics, inpatient surface antigen positive, it went up to 30% in the entire population. And not surprisingly, when you look at the geographic distribution, and the eastern part of the country has around 10% of Delta seropositivity rate, and it goes down to 3.4%. And in total, when you add up all these Delta cases, in Turkey, it's like 170,000 Delta cases is all around. Well, but when you look at this slide, although it looks like this is all wrong, because none of the prevalence studies in this meta-analysis included the immigrant population. They did not take into consideration. So we really don't have the immigrant population when we're talking about these numbers. And we know that we have about 10 million immigrant population in Turkey, from Syria, and all around the world, where there's a Delta seroprevalence is quite high. So when you look at this slide, these numbers, they're probably wrong, and it should be a little bit higher than the numbers that you see over here. So update on prevalence of Delta. I can say that prevalence of Delta is decreasing due to universal vaccination, but it's also in a rise in some countries where there is uncontrolled immigration. So how about screening strategies? I mean, basically, AASL, AASL are on the same page, but AASLD is in a totally different page on this topic. AASL believes that you should screen every surface antigen case. AASLD believes that you should go with risk-based testing. I mean, if the patient is a high-risk one, then screen them for Delta. But AASL and AASL recommends reflex testing. How about reflex testing? Which one is better? To be honest, reflex testing looks like better. This is a nice French study. When you go with risk-based versus reflex testing, you diagnose 80% more Delta cases compared to the risk-based ones. And because you diagnose these patients at their early stages of the disease, then you have less amount of cirrhotics, you have less amount of hepatocellular carcinoma, liver-related death, and need for liver transplantation. So catching these these patients at an earlier age helps when we're dealing these patients. And it is also cost effective because liver-related complications will decrease about 37% in these patients. So I think screening with reflex testing sounds better. But things are changing in US. This is a nice editorial published from Fontana. And in this editorial, he says that, so for now in 2024, we recommend that all patients with newly diagnosed hepatitis B infection undergo for testing for C, Delta, and HIV co-infection. So I think the reflex testing is going to be in the next guideline of AASLD. So after talking about these, there are a couple of hot topics, I mean, especially for young investigators to perform research on. One is non-invasive tests specific for Delta. Well, we know that chronic Delta infection causes significantly greater amount of inflammation, and the disease progression is faster, and HCC occurs in these patients at an earlier phase. So then things are a little bit different for Delta. So when we're talking about non-invasive tests, these are the blood tests that we use that are validated for hepatitis B and C, but we also have, the elastography over here. Some authors believe that we should find a non-invasive testing method for Delta hepatitis to understand how bad is the fibrosis and when we're talking about patient scores. So here are the scores, Delta fibrosis score and Delta 4 fibrosis score is over here. This is not an easy one because it has cholinesterase over here, but this one, it really looks like it could be done in daily practice. And when I looked at the validation study, it looks like the ROC validation cohort was 0.94, which is perfect. I mean, couldn't be better. So Delta 4 fibrosis score is it might be a new tool for non-invasive testing of Delta cases, but it needs validation, of course, with larger cases. I'd like to mention about a couple of abstracts from the last AASLD. Well, it's good to predict which patient is going to respond and which patient is not going to respond or has a relapse. Well, we know that baseline and on-treatment HDV RNA level is a good predictive marker for treatment of Delta. But this study, this is a nice abstract from the last AASLD, checked the core antigen levels, and they found that when you put the patient of bulevirtide treatment, core antigen mimics the HDV RNA decline and an ALT normalization. And as you can see over here, this is the S antigen, and the core antigen and the HDV RNA and ALT went all the way down. This is another abstract. I did not, of course, have the details, but they did something different. They checked the S antigen isoforms as a biomarker for predicting virological response to bulevirtide treatment. So these are interesting topics, especially for young investigators over here to work on, to understand which patients are going to respond and which patients are not. So let's move on to the treatment part. So when we're talking about treatment, we have bulevirtide, which is an entry inhibitor. We have immunomodulators like interferon, and we have lonafarnib over here, which is a prenylation inhibitor, and we have NOPs over here, the S antigen releasing inhibitors. And right over here on the below, there's the monoclonal antibodies, which I like a lot. I think the future might be over here. The monoclonal antibodies, especially 3434 and 2218, seems promising. So what does the current guidelines recommend for Delta treatment? Well, AASL looks better. I mean, when you even look at the slide, it gives you a lot of options. I mean, you could just go for pegylated interferon, 48 weeks or longer. BLV, duration depends on you according to response. You could also combine these treatments. But AASLD, it says pegylated interferon, 48 weeks, nothing else. So this graph, I got it from the AASL guideline. You know, there are sometimes you see a graph and you say, wow, why didn't I think about this? This is one of those graphs. It explains everything perfectly. If you have a chronic Delta case over here, you could go with pegylated interferon or a combination of bulevirtide. And by this way, you will treat the patient for a finite duration of time, and your aim is to cure the infection. So if it's a chronic Delta, PEG mono, PEG plus bulevirtide, or bulevirtide. But if the patient is a sick one, I mean, if it has cirrhosis, compensated, or maybe decompensated cirrhosis, then you should go with bulevirtide monotherapy. Your aim over here is to control the infection disease, and it should be for a prolonged duration of time. So it really explains which patients should receive which agent according to their disease progression. So how about new data? This is an abstract from last AASLD, a couple of months ago. We had the 3 years of bulevirtide treatment results. They put the patients on bulevirtide treatment and stopped it for a year. And it was a randomized, multi-center study, including 150 patients. About half of them had compensated cirrhosis. I want everybody to focus right over here, 2 milligrams bulevirtide. End of treatment response, combined response, was around 57%, which is quite good. But there's another thing over here that we should focus on, is that when you stop the treatment, 1 year later, it reduces down to 22%. So at the end of treatment response, although it's 57, 1 year later, it reduces down to 22%. So this slide tells us that, yes, bulevirtide is a very active medicine. It's effective, but maybe we should consider continuing the treatment like we do in hepatitis B and not stop it, because, I mean, as you can see over here, it goes all the way down. So how about real-life data? This is a nice study from Europe, 244 chronic delta cases, and all of them are compensated cirrhotic ones. It's just like the phase 3 trials, 120 weeks of treatment, 56% of the patient has combined response, ALT normal, RNA negative, which looks good. And when you look at the details of, another thing that I would like to mention over here is that, yes, we have virological response. Yes, we have combined response. But does these impact the patient's clinical course? Does it bring an outcome to the patient? This study is a nice one, trying to understand that. It's a retrospective, multi-center, real-life European study, including 176 cirrhotics versus controls. As you can see over here, all this virological response has an impact on patient's course. Liver-related events were lower, de novo HCC was lower, decompensation was lower, and mortality was lower compared to the control ones. Although they're not statistically significant, but it gives us an idea that all those virological response has a clinical impact on patients' course. I think this is a very important study which was presented a couple of months ago at AASLD. So this is another study. It focused on combination treatment of pegylated interferon and bulevirtide treatment. It was, again, an abstract a couple of months ago. They had 174 patients. They put them on pegylated interferon on one arm, interferon 48 weeks, and bulevirtide 2 milligram, interferon 48 weeks, 10 milligrams bulevirtide, and monotherapy with bulevirtide 10 milligrams. So what they presented over there was the S antigen response. As you can see over here, the S antigen response was much better than the monotherapy over here. It was much better than pegylated interferon and the bulevirtide arm. So when you use combination treatment, you have a better S antigen response, was presented over here in this in the meeting. So this group also published a new article in New England Journal of Medicine a couple of months ago. As the same group looked at the virological responses after 1 year stopping it. It looks like the combination is also better than the monotherapy group. Although they also said we did not compare 10 milligram versus 2 milligram. It wasn't head-to-head. But as you can see over here, the combination treatment is much better than the monotherapy group when we're talking about virological response. And it was published in New England Journal of Medicine last month, I think. I'd like to say a couple of words about this monoclonal antibody agents. Well, these are interesting agents. This one, the 3434, has basically two effects. It inhibits viral entry, neutralization effect, and it also clears the free variants, which is opsonization effect. The other one, it reduces the S antigen production. So basically, they work in different ways. So this study was from last year's AASLD. When they used it as a monotherapy, this was the S antigen response. Yeah, it went a little bit down, but it wasn't that good. But when they used it in a combination, they had a very nice S antigen response that they presented in the last year's AASLD meeting. The same group, this time, they wanted to check the combined endpoint with treatment. ALT normalization and getting the HDV RNA negative. As you can see over here, which combination, they had about 63% response rate when the two molecules were used together. Although the numbers are small, it's just 7 patients and 11 patients, but like I said, these are agents that I think might be handy in the future treatments. So as of 2025, Valentine's Day, what do we have for Delta? like I said, we have interferon, combination, monotherapy, depending on the chronic hepatitis or the cirrhotic case. But I really like this algorithm. I mean, I think it's time to decide case by case and according to their response to the treatment. So this is a nice one, actually. I mean, you start patient with bulevirtide 2 milligram, you go for 6 months. If you have a good response, continue the treatment. But if it's less than 2 log, just continue for 3 to 6 months and then check the HDV RNA. If your response is not that good, if things are not working for the patient as good as you expect, then you could add pegylated interferon to the patient and see how it goes. So I think starting monotherapy and deciding on the way according to the response sounds a reasonable approach as of 2025. So in conclusion, I can say that the prevalence of Delta is decreasing due to universal vaccination, but it is in a rise in some countries due to uncontrolled immigration. Risk-based screening seems to be missing a lot of cases, and double reflex testing must be promoted. I think it should become the standard approach. BLV monotherapy up to 3 years, 55% combined end of treatment response, but like I said, it decreases to 22% after 1 year follow-up. Combination may be an option, especially in low responders. And NOPs and the monoclonal antibodies and lonafarnib, they're promising agents, and hopefully we're going to find something new in the future for Delta hepatitis. And for my last slides, I was thinking about what could be the critical questions and topic for research. I think these topics, I mean, covers a little bit. I mean, first of all, we have to understand the prevalence of Delta. I mean, everybody should find their Delta cases. I think it's higher than we think. Another thing is Delta is different than hepatitis B. So we know that the disease progresses faster. We know that there's a lot of HCC over there. So we should understand what is the pathophysiological mechanisms that drives to cirrhosis and HCC in Delta in individuals. This is, I think this is a nice topic for young investigators for research. And another thing, HCC screening. I mean, should we recommend early HCC screening in patients with Delta? Because we know that HCC occurs a little bit earlier than hepatitis B. And other than that, what is the optimal treatment duration for Delta agents? And how about combination therapies? And treating decompensated cirrhotic case, it's still a struggle, and we should work on that. And understanding the reactivation and relapses in those who have cleared Delta infection is another topic, because we have no idea who's going to reactivate and who's going to have relapse. And these looks like a good research topics for the young investigators over here. So I'd like to say a couple of words about Hepatology Forum as the chief editor. We're a very nice journal. We accept good quality papers. We're in PubMed. Impact factor is 1.2, and so that's it. So like I said, it's a connect meeting, and let's stay connected where two societies love each other for the good of liver. Thank you.
Thank you very much, Professor Bülent Ertekin. This excellent presentation. I would like to invite Professor Paul to speak about the hepatitis B cure. Please, microphone is yours.
Thank you. And the second last presentation, thank you for staying till the end. And we'll get through this. And I'll just show you some of the exciting data. You've had some nice allusions to this. Disclosures. So we have just heard about the first-line therapies, and all of you know they're great. So we have entecavir, 2 tenafavirs, and they suppress viral levels very effectively in the vast majority of individuals used in pregnancy, and this is well established. However, the drawback of these is that you really don't get that much of a surface antigen loss. Oh, you do get it, and I'm sure all of us have had these patients we follow for decades, and these people, a few of them, 1% per year, they'll clear surface antigens, but it's not very high. If you add interferon, it goes a little bit higher, but at least in the US, interferon is not a drug that is very popular. What we really want to do is aim for functional cure. So what does that mean? That means clearance of surface antigen, ideally with production of surface antibody, but likely not as important. We suppress the virus, and again, we want to wind up with surface antigen negative, which is, again, our definition of functional cure. So why do we aim for this? There's lots of positive things for this. Number one, we avoid the risks of long-term nucleoside analog toxicity, reduce costs associated with lifelong therapy, avoid risks of hepatitis flare with discontinuation of therapy, and we'll talk about this a little bit, and reduce the risk of reactivation as well. Doesn't eliminate it, but it certainly reduces this. And you know, patients also, they're not very fired up about taking a drug for the rest of their life. And obviously clinical outcomes also improve. All good things happen with surface antigen clearance. Your risk of hepatocellular carcinoma goes down even further. Your surface antigen clearance also reduces the risk of decompensation episodes. So as we talk about the new therapies for hepatitis B, do you routinely send quantitative surface antigen in Turkey? Do you know? So we've just gotten this into the United States. There are a few commercial labs that do this. You know, the AASLD guidance for hepatitis B is about to come out, but the last guidance really didn't have much in the way of recommendations for surface antigen, though it's available in a few of our commercial labs. If you're low, less than 1,000 international units, this means you're likely an inactive carrier. We can use it to predict response to interferon and even to nucleoside analogs. These are potential uses, though there's nothing in our practice guidance that says we use it routinely. But for the novel emerging therapies, quantitative surface antigen is something we're all going to have to become fluent with. And this is just a potpourri of the current drug pipeline for hepatitis delta. It kind of looks like AASLD, doesn't it? And just like with AASLD and just like with hepatitis C, there's going to be a graveyard of these medicines. Many of them won't make it, but I think we're seeing that some are on their way to approval. And we're going to go over just a few of the data that are a bit more mature. So one of the major classes, and the class actually that is closest to approval that is novel for hepatitis B, not Delta, where Mercudex or bulevirtide is actually probably the closest, is advantages of targeting HBV RNA therapies. And what this means is these are therapies that degrade the pregenomic RNA, and because they can degrade all of the messenger RNA, these hinder all the hepatitis B proteins. And this is, there are a variety of technologies to do this. This reduces the surface antigen and then theoretically allows reconstitution of the immune system to try and clear and affect surface antigen. There are two classes of these. There's the antisense oligonucleotide. This is bepirovirsen, and then there's a number of silencing RNAs as well. So how do these therapies work? So silencing RNA, it's shown on the left here. You have this conjugated RNA here. It's double-stranded, and it has this glide strand which it, can hybridize with the messenger RNA, and then this RISC complex can actually, which is the silencing complex, can come in and it can degrade and cut the messenger RNA in the cytoplasm, and it does this for all the major proteins. So that's silencing RNA. And one of the things about silencing RNA is one RNA silences multiple messenger RNAs, and the dosing is not that frequent, anywhere from 2 to 4 weeks. Antisense oligonucleotides, these are short DNA, not RNA, but DNA peptides, and these are flanked by RNA-like segments. This uses a GalNAc uptake mechanism, but it's highly taken up in the liver. And again, there's an RNase which is mediated, and it targets the messenger RNA in the cytoplasm as well as the nucleus. And one antisense oligonucleotide targets one messenger RNA. Why is that important? The injections are more frequent. They're weekly. The other important thing about antisense oligonucleotides, which may be why they are in the lead for potential approval, is because they seem to also stimulate TLR, TLR8 specifically activity. And it's this extra immune burst, which seems to, in combination with the inhibition of messenger RNA, lead to better clinical outcomes. And again, 2 years ago, to great fanfare, MF published this paper in the New England Journal, and this was looking at 24 weeks of bepirovirsen, which is again is an ASO given weekly in chronic hepatitis B. They gave this on a weekly basis, 300 milligrams for a total of 24 weeks. There were also other durations, other doses, and there were also 12-week durations and doses as well. And the outcome, the primary endpoint, was clearance of surface antigen below the lower limit of detection, as well as HBV DNA undetected for 24 weeks. And it had to be the entire 24 weeks, no blips allowed. And so they looked at all levels of surface antigen, and the primary outcomes are on your table on the right. And so you can see that for those individuals who are on NUCs, that that's group 1, this surface antigen loss functional cure rate was 9% with 6 months of treatment. Not receiving NAs, it was 10%. If you had a lower baseline surface antigen level, 3,000, and this is why you have to pay attention to surface antigen levels, because it is clearly apparent that we're going to be curing the low surface antigen levels first with our therapies. But surface antigen levels less than 3,000, 12%, and if you weren't receiving a nuke, it was 25%. So first study to demonstrate increase in functional cure rate over interferon or nucleotide analog, and again, the phase 3 trial is ongoing. The other, this is just at the AASLD, this was a late breaker, and this is another ASO, this is AHB 137, and in this one, again, similar, 6 months, they only looked at those with surface antigen levels less than 3,000, but look over here in the green at the higher dose, 300 milligrams. This was the week 12 data, and 62% of individuals lost surface antigen. Actually, at week 24, it was up to 70% cleared surface antigen. Now, there's still a chance a bunch of them are going to relapse, okay? So, you know, we can't get too Pavlovian about this data, but still very exciting. And just we'll have to see how this works long term. Probably at EASL we'll see more data on this. But again, it just shows the ASO is a very viable pathway. Let's talk about silencing siRNA. This is also messenger RNA. And so this is the very first generation. This was J&J 3989, currently owned by GSK now. But this was a dose of 200 milligrams. But look at the pattern. So it's dose dependent. And you can see the RNA levels go down very nicely, right? It's beautiful. They don't go away. And they seem to plateau over time. You can see this is up to 48 weeks. And there are no functional cures that are achieved. Unlike the ASOs, no functional cures are achieved with this particular regimen. And so the strategy was to try and get the virus down, or the surface antigen level down, but then stop and see if then you could just achieve functional cure, just like you do when we stop a nuke. And I just show this slide because we're all going to have to be careful with this. So this was in the clinical trial. They stopped at the siRNA, and they stopped the tenofovir, and they followed. And of course, in a clinical trial, you're followed rigorously. You can see here that after the TDF was stopped, and that's right over here at the bottom, you can see the patient got hospitalized and actually developed a acute liver failure and wound up with an emergency liver transplant. Okay, and this was in a clinical trial. So you have to be careful with stopping therapy. And again, therapies that clear surface antigen are better. So just we all have to be careful with this. Looking at some other siRNAs, I'm just going to show you a potpourri because this has been the most studied class thus far. And you can see here, this is the VIR-2218 siRNA with or without interferon. This is combination therapy in cohort 5. Now, very small numbers, but 30% surface antigen seroclearance rate. Okay, very small numbers here. This was published in the New England Journal. This is zalnirsaran. This was the Genentech, and this was with interferon or their own TLR7. And you can see here the functional cure rates were up to, they're over in the far right, 23%. And again, these are small numbers. And this was siRNA plus an immunomodulator. And Dr. Kim talked about interferon being still used. Interferon is like the unwanted house guest that keeps paying the bills. Nobody likes the drug. Okay, it's got all kinds of side effects, but it is predictable, it stands the test of time, and actually it's the one consistent immunomodulator that actually does seem to reduce surface antigen rates. No one's a fan of interferon. Okay, but it works. At the liver meeting, there was this late-breaking poster. This was another siRNA, imdusiran, with short courses of pegylated interferon in virally suppressed e-antigen-negative individuals. And again, here, small numbers. And they notice again here, the functional cure rate, 50%, right? And that's actually quite exciting. Except you can see here, less than 1,000 in the bottom left, and it was 3 out of 6 patients. Again, small pilot study, but your foot in the door. Larger studies obviously are warranted with this medicine. So as you can see here, low surface antigen levels, and remember 1,000 is considered inactive carrier. These look like individuals who are going to have treatment options fairly soon. You know, this isn't the group that we need is the highest priority to treat, but again, once we start getting therapies that clear surface antigen, just like we have with DAA therapy for hepatitis C, we treat everybody with hepatitis C, right? We never just say, oh, just a little bit of hep C, we'll leave you alone. Everyone gets treated. We have therapies that clear surface antigen, everybody will get treated. I mean, that we will affect functional cure. And then finally, this was kind of interesting. It's a therapeutic vaccine. This actually elicits a T-cell response. And this was combined with nivolumab, which is a PD-1 checkpoint inhibitor. And they combined these two. But again, look at the population they studied. Surface antigen levels less than 200. Okay, so again, just to show that these will be adjuvant therapies, right? I mean, you're not going to clear your average hepatitis B person with this. This is 200 international units. And what they found was that 8 patients out of 69 achieved surface antigen loss. So again, you can think that these therapeutic vaccines will be something that'll just push you over, right? I mean, you'll have to have other therapies. Maybe the therapeutic vaccine is a little bit of an assist, but it's not going to be the driving force with this. What about capsid assembly modulators or core inhibitors? This is a direct-acting antiviral agent. A couple of years ago, this was just to great fanfare. And how do these work? There are 2 types. There's CAM-E and CAM-A. They're shown up here. So the way you can look at it up here is there's it either generates an empty normal capsid. So just think of that, you know, this is the core protein. It inhibits the core protein that goes around the pregenomic RNA. So you either get an empty normal capsid. When I talk to patients about this is an empty eggshell. Or you can actually get a broken eggshell. And that's CAM-A down there, where the capsid breaks up. These have been tested, and they certainly reduce HBV DNA levels. Only recently have capsid inhibitors been shown to actually have a signal to reduce surface antigen. And this is the Alagos 184 capsid. And you can see here, there is in the right graph here, on the left graph is HBV DNA. This is a capsid inhibitor. It's just as potent or more potent than entecavir. So that's actually quite good. There's a resistance, none to date. But look at the surface antigen levels. Again, early days up to just 6 months. But look on the blue. Surface antigen levels are going down. And capsid inhibitors, in theory, inhibit the recycling of cccDNA. And so they, in theory, should be able to reduce surface antigen levels. No one's been able to show this to date, but this is the first signal that this one may be of sufficient potency, and it's the latest generation. Let's talk about swinging for the fences. So these are 2 trials that are ongoing now, and if these work, and we'll know by the end of the year, this is just marvelous. cccDNA silencing. So there are 2. So there is a therapy that looks at a lipid nanoparticle that encapsulates an ARCUS mRNA that encapsulates an ARCUS nuclease. So what does that mean? So this nuclease goes into the HBV-infected hepatocyte, and it cleaves this and eliminates the cccDNA, right? Because that's why we can't clear, right? That's why it's hard to get a functional cure. This cleaves the cccDNA, and it also gets rid of the integrated DNA as well. In theory, in animal models. This is just starting clinical trials. If this works, then if you can eliminate cccDNA, nothing else matters, right? I mean, surface antigen goes away then in these individuals. And so this is under clinical trial. And there's a separate another very interesting set of trials that are starting this year. And this is looking at an epigenetic silencer of cccDNA. So this is a study, and this is on the right. And what they do is they use their compound, which is TUN-401. This is a liver-targeted lipid nanoparticle that encapsulates an mRNA and genomic RNA, and the mRNA is translated into an HBV epigenetic silencing protein. What does this mean? It methylates the cccDNA so you don't make surface antigen anymore. And so it also methylates the integrated DNA as well. And so if you silence both of these through methylation, then the surface antigen levels will go down. In theory, then, all your immune decoys from the surface antigen are gone, and you should, in theory, be able to clear surface antigen and have immune restoration. Also entering clinical trials, by the end of the year, we're going to know. Really interesting if this works. Couple, just wrapping up, immunotherapies with potential utility in chronic hepatitis B as adjuvants. So we've heard about some of these as well. You know, so immune checkpoint inhibitors are very, very interesting. The problem is the off-target effects. Who here has seen a checkpoint inhibitor toxicity? It's the heart, it's the stomach, it's the liver, and so these are the problems. There are now liver-targeted immune checkpoint inhibitors that are being initiated. So these will hopefully have fewer off-target effects. Again, immune modulation with toll-like receptors. There was one with the Genentech semaglutide, and it didn't seem to have much of an effect. There are therapeutic vaccines. I showed those, and then immunoglobulins as well that can neutralize the hepatitis B surface antigen. As we'll talk about these monoclonal antibodies, you know, you can put huge amounts of them in the circulation without any particular concern for toxicity, and they clear the surface antigen, right? There are billions of surface antigen particles in the serum, and these are being studied. We already heard about it with Delta, and this will hopefully reduce T-cell exhaustion, right? T-cell exhaustion occurs because there's so much surface antigen there, and also may inhibit viral entry. So here's a combination of a siRNA and a monoclonal antibody that was presented as a late breaker. And you can see here that when you combine these, the surface antigen loss was actually quite significant here. Overall was 22% when given for a total of 44 weeks. And then, but again, you have to look at surface antigen levels. If the surface antigen level, the overall was 22%. If your surface antigen level was less than 1,000, 48%. Greater than 3,000, it was 6%. So again, not great, but it's a surface antigen loss, and this is also being studied. So to wrap up, let's just talk about how, and this is my magic crystal ball, about how I think this is going to play out. So I think strategies for hepatitis B, I'm adding Delta. I didn't really talk about Delta, but if you cure B, you clear D. So you're going to need replication inhibition. And this, of course, nucleoside analog, right? We have them, and that certainly works. Will combining with entry inhibition, bulevirtide, monoclonal antibodies, or another replication like a CPAM, you'll need one of these, I think, maybe two, to achieve functional cure. You need to reduce the surface antigen. You need to reduce the immune decoy. And the real question that I think we're going to learn in the next 5 to 10 years is, does driving down the surface antigen level pharmacologically with an siRNA, with an oligo, just getting it down temporarily over 6 weeks, is that to 24 weeks or 48 weeks, is that enough to allow a durable immune response, the immune system to wake up, the exhausted T cells to wake up, to help clear surface antigen, just like long-term, 1% per year it happens, right? Does that, if you do it pharmacologically, will you get the same type of immune response? And again, the ASO technology looks pretty good, and I suspect is on target. I mean, it's not up to me, but the phase 3 trial will be reported fairly soon. It'll be very fascinating to see those results. Again, less than 3,000 international units for surface antigen. Immune modulation, I think you're going to need it. Who will you need it in? If you eliminate surface antigen, do you really need an immune modulator? You still might. I just point out, every time we add interferon, the side effects go up, but so do the surface antigen levels. So it clearly works. And thus far, this is an adjuvant to replication. And finally, I talked about a few of these other therapies, like the T-cell vaccine, anti-PD-L1, et cetera. These will be minor adjuvants, in my opinion, to this therapy, but it will boost, and again, to help boost the immune system, particularly if you find one with minimal side effects, I think that's going to be a valuable addition as well. I'll stop here. Sorry, I went over by a minute.
Thank you very much, Professor Paul, for this excellent speech. I would like to invite all the speakers to the stage for discussion and questions. We will have a few questions because of the time.
I have a comment.
Yes, Professor Yasemin. Yeah.
Okay.
If you keep saying EASL is somehow better than AASLD, I'll have to disown you.
Yes, actually, you're right. But I said that we're in love with the AASLD. I mean, it's a love relationship.
I think that the difference is that US FDA has not approved bulevirtide, so that really colors your impression.
I want to ask a practical question. As you know, if the quantitative HBs antigen decrease lower than 100 units, we may stop the nucleotide treatment. In some of my patients, they become viremic, but at very low level, like viremic carriers. So what do you do? Do you restart the treatment or just keep on observing them? Since I am worrying about the HCC development in those patients who are usually over 50 and male.
To clarify, what happens?
After stopping the nucleotide treatment, if the patient becomes viremic again, but at low level, what do you do? Do you restart the treatment or just observe them?
I don't have a lot of experience. At Stanford, we have a protocol that we monitor these patients. I guess it depends on how high the viral level is. If it is just tens or hundreds, we probably will leave them alone. But if it goes over a few thousand, then we end up treating.
And if the ALT goes up, then I tend to start treating these individuals. I stop very few of these people. At least for us, a more common scenario is they come in and they announce they've stopped their medicine. I think that's actually what we see much more commonly. And then you either try and convince them to restart, and if they don't, then the most important thing is you really do have to monitor these people. Most will do okay, but just every now and then something, presentation will really take a turn for the worst. And I think that's the most important aspect.
There's a nice paper published this month in Journal of Hepatology addressing this question. E antigen negative patients, 170 cases, they stopped, they put them on interferon treatment, one arm, the other arm they just followed. So what they found was, S antigen loss was 20% in the interferon group versus 7% in the other group, and relapse rates was 8% versus 29%. So, those patients were E antigen negative, they had low S antigen levels, they stopped it, and they compared whether having pegylated interferon would be a good idea. 1 year interferon treatment, stopping it, following for 48 weeks. So that might be an option for those patients. This month's Journal of Hepatology.
How are your persuasive properties? For us, stopping, if they're having trouble or want to stop the nuke, for us, getting them to start interferon after that, it would be quite an accomplishment.
Yeah, of course. I mean, but I mean, you know, there are those cases we give oral antivirals for maybe 10 years. We want to stop them. This might be an option for them, actually. I mean, because at the end of the day, you will have an S antigen response, and the relapse rate is low when you put them on interferon treatment. I mean, that was just a paper this year.
In the bulevirtide study, the 22% of patients who remained negative after stopping therapy, were there predictors of who was able to sustain that you could use in order to see who would be good to stop versus continue?
The only predictor was the HDV RNA level at baseline and treatment response at 3 months, 2 log decrease. Other than that, they did not report anything.
Did surface antigen help predict anything?
I didn't read it. But, I mean, that might be an option, of course.
Yeah.
When we think about the cure for HCV, we gave patients for years interferons, immunomodulator drugs, but the cure come from viral biology, molecular biology of the virus. And for hepatitis B, for the last 20 years, we are not putting patients on interferons because we have antiviral drugs, and as we don't have viral breakthroughs with the new agents, we are not trying to put patients on interferons. As we are able to targeting cccDNA, do you think that we will need immune modulation for hepatitis B? It's different than hep C. I agree with you, but as we learn about viral biology and as we target every point that we can target, do you think that we need immune modulation? I want to have the idea of the whole group.
Sure. I'll start, and then you'll get 3 different opinions. So my answer is not very satisfying. It depends. Okay, so if some of these therapies work, if you find a therapy, for instance, we talked about the cccDNA, if you can actually eliminate cccDNA, I actually think immunomodulation probably isn't going to be required. I mean, just if you so effectively silence the integrated in cccDNA, awesome. I think for some of the others, I think then duration is actually going to matter. That is, if you treat them for longer, you won't, eventually you'll get it down. Just like bulevirtide, I mean, duration clearly matters. And then you will need less immunomodulation. For shorter duration, other therapies, I think some degree of immunomodulation will be needed to push them over. That's just, you'll have to invite me back in 3 years to find out if I'm right.
Nothing to add.
So Ray has all the answers.
Of course not. I was thinking the same. I'm going to say the same thing, but I think the challenge is turning off cccDNA in every cell. Yeah. Right. If you are able to do that, then I don't think you need immunology. It becomes a pure, simple infectious disease. But to the degree that we aren't able to do that, at least as of now, that's the challenge.
Thank you very much for all the speakers. We would like to give a small gift to Professor Paul to commemorate this meeting.
Yeah, I would like to invite Professor Dr. Yurdaydın the stage to give this gift. Thank you very much. We start the case presentation. We have two cases, one presented by Onur Keskin. The other one is Zeynep Elik. Yes, Onur, will you present your case?
Hello, everyone. Today I will talk about three chronic delta hepatitis cases. I will share interesting findings that we noticed during their follow-up. The first two cases had COVID-19 infection. Although similar things happened to them, their courses were different. The third case is really interesting. We experienced an unexpected event during the course of the delta hepatitis in this patient. I have been following these patients with Dr. Yurdaydın. He's also here now. And I think his views and his contributions will be valuable in the discussion phase.
Dr. Keskin, I kindly remind you that you have only 50 minutes.
Okay. The first case is 63-year-old woman with chronic delta hepatitis. Her date of diagnosis was 1999. She had no cirrhosis at the time of diagnosis. She was on maintained virological response since October 2018 after receiving a cumulative 8 years of interferon treatment. Her liver stiffness measurement with FibroScan in 2020 was determined as 7.9 kilopascal. And in July 2020, a patient was diagnosed with COVID-19. We see that the patient's liver enzymes were totally normal and HTV RNA was negative after following interferon treatments. This situation continued for about 2 years, and the patient had COVID infection in July 2020. After following COVID infection, we observed both an increase in elevation in ALT and AST levels and positivity in HTV RNA levels. She had hepatitis D virus reactivation and elevation in liver states after COVID-19 infection. Since the patient was not cirrhotic, no compensation occurred. Now she is receiving interferon therapy. ALT is normal, but HTV RNA is still positive. HTV RNA never became negative after this reactivation. We do not know actually why did HTV RNA become positive after COVID-19 infection. I would like to continue the second case. We can discuss once the second case is over. The second case is a 52-year-old woman with compensated cirrhosis due to chronic delta hepatitis. She had grade 2 esophageal varices and no ascites. Her child score was 5. She entered lonafanib protocol on March 2020. She was randomized to treatment to 50 milligram lonafanib and ritonavir. She was diagnosed with COVID-19 infection in August 2020. At the beginning of treatment, ALT and AST levels 4 times higher than the normal, and HTV RNA was positive. With treatment, at the time of COVID, she had become ALT normal and HTV RNA target not detected, which most likely helped her to get rid of COVID without any liver-related event. We want to emphasize the importance of successful treatment in chronic delta hepatitis, as she had quite advanced cirrhosis, and she had developed hepatic reactivation if she were not treated for hepatitis D virus. Now, if you want, we can discuss the two COVID cases.
So the point is why HTV RNA positive after COVID infection?
Yes.
Okay.
So just to summarize, I mean, the first one is a chronic delta case. It's not cirrhotic.
Yes.
He was doing fine, and after COVID, his RNA became positive, and things went bad for him. The second one is a cirrhotic case. He was bad, and after COVID, he became negative. So COVID worked in two different ways. Am I right?
Yes, yes.
Was the second one on lonafarnib during the
No,
COVID infection?
they had stopped it.
Yes,
How long had they stopped it?
yes. After
Many years ago,
lonafarnib
I mean
therapy.
3-4 years ago, they stopped lonafarnib. The other one was on interferon treatment.
Steroid item?
She was on lonafarnib at the time of COVID-19 infection. So she stopped lonafarnib as per protocol after, I think, 5 months after COVID-19, and nothing happened during the treatment with lonafarnib. That's what I heard.
So let's take the first one. So did they take, for their COVID, did they get dexamethasone?
No, her COVID was not severe, and she didn't receive any steroid treatment during COVID infection.
Curses. There.
Do you think it's related with the COVID infection or the natural course of the disease?
Yes, you are right. The COVID may not be related with the hepatic reactivation. We know that in the long-term results of EDIT-1 and EDIT-2 studies show that the reactivation may be seen in long-term follow-up, and the HDV RNA became negative in these patients. But this hepatic reactivation develops immediately following the COVID infection. So the timing of this event made us think of COVID as a cause.
Murat?
In COVID-19 era, I saw a patient who has HBs antigen negative and anti-HBC antigen negative, but anti-delta positive. I think COVID-19 can carry delta virus instead of hepatitis B. What do you think?
Maybe. We don't know actually.
Possible.
You know,
COVID is a severe infection and may result in cytokine release, sometimes cytokine storm, and these cytokines may disturb the relationship between the immune host system and virus. We don't know actually.
I think Murat touched an important point because we already know that HDV RNA or anti-delta antibody is positive in HCV positive patient. HDV RNA maybe false positive, maybe the HDV is not only infected with chronic hepatitis B patient. Maybe it's an HCV patient, we can find the HDV positivity and HDV RNA positivity. Maybe this patient experienced the HPV previously.
Yes.
I have no idea.
Well, just to think a little bit, I mean, because when you're talking about COVID infection, there is like lots of cytokines and storm are going over there, and the T lymphocytes, and they're exhausted, and maybe it acts as an immunomodulator, like expressing interferon genes, I mean, overexpressing them. So maybe that caused this. Another thing is, were they vaccinated? I mean, maybe vaccines caused a little bit difference, and other than that, maybe it makes miracles.
Well, you said it was a mild COVID infection, right?
Yes.
Both of them are
not severe.
Not severe. And did you have she had known Delta before though, right?
Yeah.
Just HDV RNA negative.
Yes, at the time of COVID, HDV.
Can you go back? How high did her DNA levels go up after COVID? How high did they go? I can't remember. I'm sorry, I don't remember. Can you go backwards? There you go.
I mean, I just want to say that this patient is on lonafarnib, and in this patient you don't have an increase in HPV DNA because she was also on tenofovir.
Oh, is this the one that was on lonafarnib, or was it the cirrhosis?
What's the other one?
It's the other one. This is the first patient.
This is the first patient. This is the second patient.
Yeah, this one was, but can you go back to the first one?
Case one.
Negative. HBV DNA negative.
First case becomes positive, and the second case becomes.
Yes, that's correct.
I think that's just, these cases tell us how little we know about immunology.
Yeah.
I don't have any big wisdom, but you know, you guys have much more experience dealing with these patients than I do. In my career, I can think of 2 cases where Hep B patient, on treatment or not, they go through a severe medical event not related to the liver. One had a heart attack, and the other, I forget, some kind of really major illness. And a few months later, they clear hepatitis B. And the only thing I can think of is something in their body happened that really shook their immune system and allowed hepatitis B to be cleared. And I think that the second case feels like this significant systemic event. Like Bülent said, who knows what the cytokines and everything else do in these human bodies. So I just think we need to stay humble that this is probably related, and whether COVID works to the advantage of the patient with hepatitis B or against, we just don't know what happens. But I mean, I don't know. I just don't know. Yeah.
So the second case makes more sense to me, like I think they're saying, because I actually had a patient who got chemotherapy and became severely immunosuppressed. And then when she kind of reconstituted her immune system, actually had a sustained virologic response to hepatitis C, which that only happened to me once. But the immune system is a very powerful tool, and it should actually clear all of these viruses. It's just that the liver is somewhat of an it's a bit of a protected environment because, certainly know that from transplant with the lower immunosuppression required in transplant of the liver compared to other organs. But I'm not sure I understand the first case.
I mean, can we talk about a little bit about this paper and then go to the third case, because we should actually discuss all the cases together, because I think that the third case is also interesting and related somehow.
Continue. Our study on the consequences of COVID infection on hepatitis B and hepatitis Delta patients was published last month. Due to our study, hepatic reactivation occurred more commonly in chronic Delta hepatitis and more frequent in cirrhotic cases. Although the small number of chronic Delta hepatitis and COVID infections limits the definitive diagnosis, chronic Delta hepatitis may experience more severe course of COVID-19 infection compared to chronic hepatitis B patient. This may be due to higher proportion of cirrhotics among chronic Delta hepatitis patients and the lack of effective antiviral treatment for hepatitis D virus. The third case is 60-year-old male. He was diagnosed with Delta hepatitis 13 years ago. You can see the liver enzyme, elevated liver enzymes and positivity in HDV RNA at the time of diagnosis. Immediately after diagnosis, pegylated interferon treatment was started to this patient. This patient can tolerate interferon treatment for only 3 months, and at the end of 3 months, no response was obtained in this patient. Following 3 years, between 2011 and 2014, he received no treatment, followed without treatment, and the patient entered phase 2 study of lonafarnib on 2014. He received received lonafarnib 200 milligram and pegylated interferon. He was able to receive this treatment only 1 week. At the end of 1 week, the treatment was stopped due to severe adverse events. After stopping treatment, patient continued to be followed at Ankara University Medical School at 6 to 12 month intervals. His HPV DNA was negative, and he did not receive any treatment for hepatitis D and hepatitis B viruses. In the following years, the patient clinical and laboratory status didn't change. You can see elevated ALT levels and the positivity HDV RNA. Quantitative hepatitis B surface antigen levels always been measured high throughout the entire follow-up of this patient. Until 2019, in his laboratory test showed that sudden increase in ALT levels. ALT was detected as 419, and after this flare, following 2 years, the hepatitis B surface antigen disappears, HDV RNA became negative, and ALT normalization occurred in this patient. Hepatitis B surface antigen loss in chronic delta hepatitis can be seen. It may develop following successful treatments. In our patient group, in patients who achieve maintained virological response, cumulative probability of hepatitis B surface antigen clearance was 37%. In non-responder, interferon non-responder patient group, only one patient had hepatitis B surface antigen loss following liver decompensation. This patient did not receive successful treatment for hepatitis delta virus. He did not display a shift of dominant virus over time. With a quantitative hepatitis B surface antigen level of more than 3,000, he was an unlikely candidate for self-clearance. Asymptomatic and milder forms of chronic delta hepatitis was published in all publications. Due to this study, 1/4 of untreated chronic delta hepatitis patients showed a more than 2-log decline in HDV RNA, and 20% reached the HDV RNA negativity in long-term follow-up. Hepatitis B surface antigen loss was documented in 7% in this patient cohort. In this study, hepatitis B surface antigen loss develops spontaneously, not following a flare. Another concept in this subject is chronic delta hepatitis patients with persistently normal ALT, HDV uremia. Okay.
Could you?
Last slide, sorry. Okay. This can be defined arbitrary patients with ALT, normal ALT, and HDV uremia 3 to 6 months apart within 2 years without interferon treatment. This does not imply the milder disease because these patients may develop advanced fibrosis. Going back to our patient, this is the summary of the patient, and patient had a flare at that point, and following this flare, HDV RNA negativity, hepatitis B surface antigen loss was obtained in this patient, and $1 million Trump question: what caused the flare in this patient?
I know that everyone is tired, but I'm going to give the answer because we followed this patient, as you mentioned that. We have the treatment of the Delta and HPV, but we will not say everyone. Just keep the secret.
Yes. Yes.
So first option is he had COVID.
This flare,
the second option,
this flare develops in 2019.
So maybe, I mean, when they lose S antigen, I mean, you said that 1/4 of them somehow gets better in their natural courses. I mean, we just following these patients very closely, and we just realize the flare. Maybe they're having flares, and we're not realizing them because we're not keeping an eye on them that closely. Maybe that's the explanation.
Yeah. Spontaneous hepatitis B surface antigen loss may be seen in natural course of delta hepatitis, but as we know that, not with following flare. Okay.
Okay, thank you very much, Professor Onur. We are going to move on with the next speaker, Professor Zeynep, please.
Good afternoon, dear Chairman, dear colleagues, and dear discussants. I am Zeynep Melekolu from Ankara University. I would like to present today's case. I have nothing to disclose. Our case is 58-year-old male. He has had chronic hepatitis B since 2010. He has no systemic disease or medication use. He has no family history of liver disease, and the physical examination findings were normal. Initial laboratory tests were as follows. Liver enzymes, ALT, AST, GGT, bilirubin were elevated. Hepatitis B surface antigen and E antigen were positive. HBV DNA level was 170 million. The hepatobiliary ultrasonography showed grade 1 hepatosteatosis. The liver biopsy revealed a histological activity index of 6 and fibrosis of 2. Based on these findings, anti-recovery treatment was initiated in 2011. Treatment was well tolerated. During the follow-up period, hepatitis B E antigen seroconverted to hepatitis B E anticore, and HBV DNA level has been negative for 8 years. In August 2020, hepatobiliary ultrasonography showed grade 2 hepatosteatosis. The fibrosis scan indicated a CAP of 334 and elasticity of 6.8. He is a non-cirrhotic chronic hepatitis B patient, hepatitis E antigen seroconverted, and he received antiviral treatment for 9 years. What is the next step? Antiviral treatment was discontinued in 2020. These are the laboratory values after treatment discontinuation. His liver enzymes were normal. HBV DNA levels were low. Also, hepatitis B surface antigen were positive. What is the next step? Should we perform additional tests and follow-up?
What was the gap between seroconversion and stopping the antiviral?
About 9 years.
Sorry?
9 years.
No, more than 1 year. You're asking the after seroconverted, E antigen seroconverted to E antibody, more than 1 year.
Yes.
Yes. The question is, the patient received antiviral treatment more than 9 years and E antigen seroconverted. Would you discontinue the antiviral treatment, avoid the risk of the antiviral treatment?
Okay, so they
I mean, since additional, the question is, should we perform additional tests and follow up? The surface antigen levels which have been described in the table are not quantitative surface antigen levels, first of all.
No,
yes.
it wasn't quantitative.
Yes, so if I would stop treatment in a patient with chronic hepatitis B, I would not do it before knowing quantitative surface antigen levels. We don't have correlated antigen. We don't, we can check HBV RNA actually as a research tool, but we cannot do correlated antigen, but at least quantitative surface antigen levels. As in the US, we have it only in private labs not at the University Medical School, but it is, at this point in time, we should not, everything pushes towards that, but we should not treat any patient with chronic hepatitis B without knowing, without looking at quantitative surface antigen levels. This is a must, I think.
Yeah, so in this particular case, it sounds like they had an adequate period of consolidation after clearing E antigen. So the practice guidance would say you could stop. There are those of us who don't read practice guidances, and some of us would just keep the patient indefinitely on the nuke at this point.
Paul, the question is, after 3 years of treatment and discontinuing the treatment, ALT was normal, HBV DNA is a little bit high. She's asking still, she will be continuing this follow-up to this patient.
So, right, and what I would say, I would probably do one of two things. It's a conversation with the patient as well to see how much they want to take it. Some of them just don't want to take it. The only other thing that I would do is I would do a FibroScan. And if there is significant liver stiffness, I would start it.
It was 6.8 when discontinued treatment.
No, when it went up. No, 6. I'm talking about when the HBV went up. In other words, when they come to us, I would re-FibroScan just to see if the liver stiffness was increased.
Okay. The other point is this patient has hepatosteatosis. The muscle D. How can you differ? Is this increased elasticity is related with the HBV or muscle D?
Well, you look at them. You can look at them and decide if they've gained a lot of weight since they came off. That's number one. Number two, that would actually be a further incentive for me to put them back on the therapy, because if they have muscle D, I'm looking for anything that would reduce any risk of progressive liver disease. And the other thing is hepatitis B, you're already at increased risk for hepatocellular carcinoma without cirrhosis. Muscle D also, you're at increased risk for hepatocellular carcinoma without cirrhosis. In my practice, I would be leaning on them. I would be leaning on them to go back on treatment. Just me with the HBV, what was it, 18,000 or whatever it was.
Can I comment? Do you perform liver biopsy at that stage?
I would not. It is perfectly reasonable to do a biopsy at that stage. Getting them to agree to it would actually be you'd have to be quite persuasive.
Well, at this point, we have two options: start treatment or wait and see what happens. If we start treatment, what we do is every 6 months see ALT and AST. First, we see that HBV DNA is negative, and then what we look for is every 6 months AST, ALT, and every year ultrasound, and that would be okay. But if we don't start treatment, then what we need to do is follow this patient every 3 months, and at least every 6 months we have to check HBV DNA, and and we have the risk, as Professor Kuo said, we have the risk of HCC if we don't start HBV, because he had muscle D as well beside HBV. So when I put these things, I'll go for treatment, because when I start treatment, everything will be smooth. So I'll go for treatment for this patient.
Can you go back one slide?
Yes.
Show us the data. So the thing that I fear most in patients who seroconvert and we stop treatment is E seroreversion, right? If the E antigen came back, or if the antibody goes away, or E antigen comes back, I for sure would restart treatment. There's no controversy, right?
You had the E antigen seroconverted before, during the antiviral therapy.
Right. But if the E antigen comes back after antiviral treatment stopped, then there's no controversy that we restart treatment.
Sure.
So in this case, we successfully converted E antigen positive active hepatitis to E antigen negative, sort of inactive carrier. The enzymes are pretty quiet, or sort of a gray zone. And here the DNA level starts to go up. It seems like it's coming back down, right? So if the patient, if the DNA continues to go down and settle around 300, say, and ALT remains normal, then if this patient becomes inactive carrier, then it becomes more difficult to decide whether to treat or not. I would give some time, because of this trend at the end, 18,000 to 2,800, that's a 1 log drop.
In Turkey, the genotype is genotype D. And we don't even check the genotype because we know that it's genotype D. And in genotype D, now if we can check, I'm for sure that this HBV DNA has core promoter mutation. So this patient now is core promoter mutation, HBe negative chronic hepatitis B patient. So in this point, I mean, this can be in genotype D, we forgot these tests because we give tenofovir and entecavir and we forget anything about the virus. We don't need to think about the virus. But as it is the genotype D in Turkey, this patient is now E negative chronic hepatitis B patient. And if we don't start treatment, we have to check HBV DNA every 6 months. And in my practice, I call this kind of patients every 3 months for ALT and AST. And if anything goes high, I'll do the HBV DNA.
Thank you, Levent. Could you go on?
Yes.
Could you continue?
Yes. In the 4th year, liver enzymes were normal, but the HBV DNA level was elevated, increased. It was...
So, at that time, I would like to ask all the speakers and audience, who one would like to start the antiviral treatment? For example, at the end of 1 year, when you check the HBV DNA high, or at the wait and see, or after the 4th year. Could you hands up?
For either one? Yeah. Yeah. Yes.
Is any comment? Yes.
Sorry. This patient is not HBV carrier, inactive HBV carrier. This is the E negative patients, you know. So this is 58 years old and more than 2,000 HBV DNA levels, and initial biopsy was showed F2 fibrosis, and also he has steatosis and he is getting older. So we have to give the
and the surface antigen level is high.
Yeah.
It's not less than 1,000.
Exactly, we give.
Yeah, so high surface
this
antigen.
Patient. Thank you.
Okay. In January 2025, the liver enzymes were elevated, and the HBV DNA was 380 million. HBV reactivation was observed 5 years after antiviral treatment discontinued. We restarted the anti-COVID treatment. The patient is now very well. After anti-COVID treatment started, liver enzymes were increased, decreased, and HBV DNA is declined. We continue close follow-up the patient now. Thank you very much.
Did you do a fiber scan, just out of curiosity, after all of that? Just to see if these over all these years just progressed?
Did you perform fibroscan?
No.
No, not yet. Thank you.
So I want to follow up. For genotype D patients, I never see. So this is a very innocent question. So when you see E antigen negative patient with normal ALT and sort of a few hundred, even 2,000 DNA, you don't consider them as sort of a inactive situation. You think of them as having active hepatitis.
Well, this patient is a bit different because this patient has a treatment history. What we see for E-positive patients, we started treatment. We saw lots of patients like this one. I mean, even it started as E-positive patient, even if it doesn't matter whether you give interferon or oral antiviral, you got E seroconversion. And then if some time passed and if there is an DNA activation, so this is a patient that you have to take care of because sometime you will, even if it's around 2,000, less than 2,000, sometime you will see a flare. So you have to take care of this patient as an E-negative patient because things change. But if at first it's an E-negative patient and HBV DNA, if it's less than 1,000, it's better. But if it's around 2,000, you have to consider, you start or you have to be very cautious because things can be changed. Even, I don't know why, in my practice, for example, if sometimes patients have toxic hepatitis due to non-steroid anti-inflammatory drugs or other drugs, and then there is an ALT flare, and then you see something like this. I don't know the reason, but there is an immune play between virus and liver microenvironment. We don't know the details like Delta patients will be so. What I do is, if it's around 2,000, I'm very cautious. And I try to start the treatment. If there is the reimbursement, I mean, if we can pay it from the insurance companies, so we can.
Do you find surface antigen titer helpful in your?
Well, it's helpful, but it's not available. It's not available.
Okay, the last quick question. At that time, during the follow-up period, how about the HBV RNA level?
RNA?
Yeah, HBV RNA level.
E antigen negative, they're probably going to be low. That's all I was saying, because but who knows? It will probably be quite low because most E antigen negatives are.
Okay. Well, thank you so much. Zeynep, thank you very much for your great presentation. I thank all speakers and moderators, Murat, and also for you for your kind contribution. I would like to invite the president of the board society for the closing session. Then we will take a picture all together. Thank you very much.